What I'm going to talk about is my program of research from my doctoral dissertation up until this point. I finished my dissertation, or my PhD, back in 2005. And like I said, I'm going to talk about all my studies, starting with my dissertation. Okay, is that my first slide? Okay. I just want to talk a little bit about a framework. I use a vulnerable populations framework that's from Flask-Root and Winslow, and I like to use, excuse me, this framework because it gives me a kind of a guide to looking at not only the health disparities that affect certain groups, but also the social factors that influence what we call vulnerable populations. And since my research is focused on all vulnerable populations, I kind of like to use it as a framework. And you can see there's different groups that Flask-Root and Winslow list as members of vulnerable populations, and my research is focused on Hispanic MSM and also on immigrants. I always like to use this slide when we talk about recruitment because my research is focused mostly on Hispanic populations, and as Dr. Mitrani listed earlier, a lot of these studies have focused on all ethnic groups and have very small groups of Hispanics. So I try as much as possible to use populations that are largely Hispanic. When I'm doing Hispanic MSM, that's easy, but when I'm using also one study that I'll talk about where I used HIV-infected individuals for another study, you can see that I try to include as many Hispanics as possible. This is my program of research. It's very busy, as you can see from this slide, but it couldn't make it any bigger. But I'm going to talk about each of these studies and the results of these studies, and I'm also going to show you, hopefully, where I'm going with this in the future. The first study that I'm going to talk about was my doctoral dissertation, Depression, Self-Esteem, and Sexual Behaviors Among MSM. And I had a sample size of 205. Now, given that Miami is predominantly a Hispanic area, I had a large number of Hispanics in my study. So even though it wasn't all Hispanic, it was largely a Hispanic study. I enrolled 205 MSM. You can see the breakdown here. 14 African Americans, 30 Caucasians, 155 Hispanics. Again, we have a very large Hispanic area, and 6 Asians. And I did face-to-face interviews where I asked them about depression, self-esteem, sexual behaviors, and any demographic, and a number of demographic variables. Here were my research questions. And again, I'm going to cover each of these studies. So I'm just going to skip this slide because I cover each of these in detail. Research question 1, what was the influence of depression, self-esteem, I repeated depression twice, and demographic variables on sexual behaviors. As you can see, depression accounted for 14.4% of the variance in sexual behaviors, but self-esteem accounted for 17%, and foreign birth and language preference only accounted for 2.3% of the variance in sexual behaviors, and none of the other demographic variables in this study were significant. So this kind of started me on my way of thinking about how mental health factors like depression and self-esteem were related to sexual behaviors. And for my doctoral dissertation, I got the idea of focusing on mental health because I did focus groups with HIV-infected men before HIV-infected MSM, actually, before I did the study. And repeatedly, they told me that they believed that the reason that they became infected was either because they were very depressed at certain periods of time, or that they had very low self-esteem that resulted in them engaging in high-risk sexual behaviors. So that idea kind of helped move my, my interest in mental health. Research question 2, I looked at comparing foreign-born and U.S.-born Hispanic MSM. Now, in Miami, a large portion of the population is foreign-born. So it was very easy to recruit foreign-born MSM, and very few U.S.-born MSM participated in my study. But I did find differences. Foreign-born men had lower depression scores, as you can see here, and foreign-born men had higher levels of safer sex behavior. So this was my other interest, where I started looking at why are acculturated men more sexually risky, acculturated MSM more sexually risky. And as I'll talk about in a little bit, this is where I'm going with another research study. The first study that I presented, going back, was published in the American Journal of Men's Health. This study was published in Hispanic Healthcare International. The third study, how does depression, self-esteem, and how does depression, I keep repeating depression, self-esteem, and sexual behaviors vary by ethnicity? And what I was interested in here, even though I had very large numbers of Hispanics, I wanted to look at some of these ethnic and racial differences. But because my sample was so largely Hispanic, it was kind of hard to do this. And I really wasn't going to pursue this research question. But when I looked at the literature, I saw that there was nothing that had been done looking at these three variables and comparing them by ethnicity. So even though it's a very small sample, it was important to look at this. And so what I looked at was that I threw out the foreign-born men, since there was a number 155 of those, and so I looked at the blacks, Asians, 30 Caucasians, and 20 U.S.-born Hispanic MSM, and I compared them in terms of depression, self-esteem, and sexual behaviors. Depression varied by ethnicity, with blacks having the highest levels of depression, and that was statistically significant. And also there were statistically significant differences in sexual, or they were not found in terms of self-esteem and sexual behaviors. Now again, this study has to be interpreted very cautiously because it was such a small sample and the groups were so unequal. And again, I wasn't going to publish this manuscript, but I was talking about this at a conference, and there were people from the Journal of Gay and Lesbian Social Services who were very interested in this study, and they encouraged me to submit the results of this study for a manuscript. So I was able to, Dr. Vasquez and I were actually able to publish this manuscript in the Journal of Gay and Lesbian Social Services. Again, because there was very little work done in this area. How do sexual behaviors of MSM vary by relationship status? I also became very interested in what's the difference of sexual behaviors of MSM who are in relationships and who are not in relationships. So in this sample, I had closer numbers of equal groups of those who were in relationship and those who were not in relationships. And first of all, I looked at specific high-risk behaviors. You can see here I talked about engaging in anal sex. 94% of my sample engaged in anal sex. 40% engaged in anal sex without condoms, which I thought was really high. And other things that came out here, they had difficulty discussing sex with both casual and relationship partners. And as you can see, alcohol before or during sex, almost 70% of the sample used alcohol before or during sex. So looking at that and looking at a number of high-risk behaviors, when I compared them between relationship status of those who were and those who were not, very few differences were found. So this kind of made me think about wanting to explore relationship status among Hispanic MSM a little bit further. And I've included in all my future studies, and the studies I'm doing now, I should say, I've included relationship status and looking at the different types of relationship that Hispanic MSM may have. This study is currently being published in the American Journal of Men's Health. After my dissertation, the next study that I was able to get funding for was through the University of Miami General Research Support Award. And I wanted to look at a cluster of health conditions that may affect Hispanic MSM. As Dr. Matrani pointed out earlier this morning, a lot of these conditions don't exist in vacuums. There's a relationship of different factors. So what I looked at here, I looked at alcohol abuse, body image, depression, eating attitudes, behaviors, self-esteem, and sexual behaviors in a community sample of Hispanic men. I collected a number of, or I used a number of tools, I should say here. I used the CAGE, the Donis complex questionnaire for body image for gay men. I used depression, the CESD, eating attitudes and behaviors, the EAT-26, which is a well-known eating attitude and behavior scale that includes questions about risk for eating disorder. I used the Rosenberg self-esteem. I used the Safer Sex Behaviors questionnaire, which I started using in my dissertation, and I looked at demographics. And so my two research questions were, what are the predictors of sexual behaviors among Hispanic MSM, and what are the predictors of eating attitudes and behaviors? Now, it's a little busy, but if you look at this using structural equation modeling, we were able to look at what are the predictors of sexual behaviors, what are the direct paths and the indirect paths. And the only direct path, which I kind of knew intuitively, but I was glad that I was able to find it in this study, the only direct path to sexual behaviors was mental health. And mental health included self-esteem and depression. Now, I also had thought that alcohol abuse would be a pretty significant predictor of sexual behaviors, but in this study, it was not. However, alcohol abuse was very closely linked to mental health, and we know that intuitively. We know that certain people with mental health conditions tend to self-medicate with alcohol. And so this study gave me a little bit more belief in the fact that mental health is so linked to sexual behaviors in Hispanic MSM. And this study was published in the Nursing Clinics of North America. So then I looked at predictors of eating attitudes and behaviors using regression analysis. And I looked at the cluster. Again, I'm interested in overlapping health disparities here. And I was interested in these clusters of health behaviors or health risk behaviors influencing eating attitudes and behaviors. And you can see here that cluster of variables accounted for like almost 40% of the variance in eating attitudes and behaviors. So I'm in the process of revising this manuscript for the Archives of Sexual Behaviors. It has been accepted with revisions. But one of the things that they really challenged me to think about with this publication is, why was it that these variables only accounted for about 40%? What could you offer for other explanations? And that was very easy, because what we did not measure here were some of the social variables that affect Hispanic MSM, mostly marginalization, possible discrimination, possible oppression. Some of these things probably account for a lot of the variance in this also. Okay, then I kind of switched gears a little bit, because I'm like I said, my research program is focused on HIV risk and HIV among vulnerable populations. And I looked at how people with HIV infection, how adults with HIV infection, experience vulnerability and resilience. And again, those are two concepts that I'm very interested in among people with HIV infection. So what I wanted to do with this study was to develop a theory that explained both vulnerability and resilience in the context of HIV infection for adults that have HIV. So my sample was, I had 15 adults in this study. This study was funded by the Beta Tau chapter of Sigma Theta Tau International. Excuse me. I had 15 adults aged 24 to 61, and they were drawn from an HIV clinic. And I had 8 females, 7 males, 6 blacks, 8 Hispanics, and 1 Caucasian. And again, I tried to enroll as many Hispanics as I could for this study. The majority contracted HIV through high-risk sexual contact, and 10 out of 15 participants had other health conditions in addition to HIV infection. And that ranged from mental health diagnoses, which a large number of them did have depression, bipolar disorder, anxiety disorders, all of these type of things. And so I asked a number of research questions that was consistent with grounded theory to find out how they describe the process of vulnerability and how they describe the process of resilience in the context of HIV infection. Kind of hard to see, but from the interviews I came up with a theory of vulnerability in the context of HIV infection. And what they talked about was the fact that they were confronted with a terminal illness or a change in health status, i.e. they progressed from HIV infection to AIDS, and that was a moment where it caused a lot of feelings of vulnerability. And there were also a number of things that happened within HIV infection that caused them to feel vulnerable. Physical changes, mental changes, changing mentation, changing spirituality. They had, as Dr. Matrani pointed out earlier, a lot of people reported that they were kind of shunned from their place of worship because they told their religious leader that they had HIV infection. So they lost this contact with their spiritual support. And they also had changes in their sociability. They lost contact with families, they lost contact with friends, they lost contact with partners because of the fact that they had HIV. And basically, all of these things in the context of a lack of psychosocial support led them to perceive or to feel that they were part of a vulnerable population. And this study was published in Issues in Mental Health Nursing. Now, the second part, because there was so much data from these 15 interviews, I had to separate out the vulnerability part and the resilience part. The resilience part, they talked about what promoted resilience in people with HIV infection. That was pretty easy for them to talk about. They talked about two sources of motivation. Either they had intrinsic motivation or they had extrinsic motivation. Intrinsic motivation was a sense of spirituality, which they found very important, a desire to survive, and a desire for knowledge. They reported that they had this desire to learn about HIV, and that helped them become motivated and to move toward resilience. Now, extrinsic motivation was the fact that they were able to disclose to other people and find support, and also the fact that they had psychosocial support. So that allowed them, again, to progress towards resilience. Now, they also talked about management of the disease. Once they were motivated, they needed to manage the disease. And they all talked about the fact that they needed to manage the physical aspects first. Once the physical aspects were taken care of, then they focused on the mental health aspects of managing the disease, which led them to mastering the disease, and mastering the disease included advocacy. Not only did they want to advocate for themselves, they wanted to advocate for other people with HIV. And a lot of them became peer educators or started going out into the community and giving talks about the challenges of living with HIV infection. Now, also in part of mastering the disease, there was a better health outcomes or more positive health outcomes. They also figured out that if they were adherent to medications, that also helped them have better health outcomes, which led to resilience. I have this study now. I worked with this study on two of our doctoral students, and it is under review in the Journal of the Association of Psychiatric Nurses. All right, moving on, talking about Project Vita, which I worked with Dr. Vasquez on, or Dean Vasquez, excuse me. I'm still not used to that. We talked about Project Vita, violence, intimate relationships, and drugs among Latinos. And this was the study that Dr. Matrani talked about earlier. And what we were interested here was getting the experiences of both heterosexual and Hispanic MSM in terms of violence, intimate relationships, risk for HIV, and drugs. So it was a two-phase study. We had a quantitative and a qualitative phase. Quantitative phase, we did face-to-face interviews on a number of instruments, which I'll show you in just a second. And we collected all that data in a very systematic fashion. We also did focus groups with both heterosexual and Hispanic MSM. So we believe that both methods in this study were important to give us an accurate depiction of what goes on in the community. So again, here's our studies face-to-face. We asked them to participate in a very large number of instruments. Probably took about 1.5 to 2 hours to go through all of these instruments here, but it gave us a lot of data that I'll share with you some of the results that we have published so far. But you can see we looked at acculturation, we looked at depression, excuse me, we looked at family, we looked at HIV knowledge, self-esteem, stress, sexual behaviors, sexual orientation, substance abuse, and experiences with violence. Okay, the qualitative portion, like I said, we did two separate focus groups. We did heterosexual Hispanic men and Hispanic MSM. And we asked them these questions. what we're looking at here is the relationship of all the factors that we talked about. You know, what's the important issues that are involved? What's the involvement of becoming a victim of violence or a perpetrator of violence? What's the process becoming involved in somebody who uses drugs and alcohol? And the same as sexual behaviors. So the qualitative study, again, like I said, we did 60 men. We used focus group methodology and, oops, where am I going here? Okay. And what we wanted to look at, again, like I said, is the experiences. Now, we're in the process of writing this up. We're in the process of writing the results of the Hispanic MSM manuscript right now. So what I want to talk about now is, let's get to the next. The first, oh, I'm sorry, the results of the quantitative phase of Project Vita. What are the experiences of Hispanic men with risky risky behaviors, and what are the associated cultural factors, and what's the relationship between acculturation, depression, self-esteem, substance abuse, and demographic factors? The first one, we looked at the focus groups. Here you can see the mean age was 44, length of time in the US. 96% were unemployed, 90% had incomes less than $1,000 a month, 80% were single, and 84% were without health insurance. So we have a really vulnerable population or vulnerable participants in this study. This study was published in the Western Journal of Nursing Research, and again, it's a little hard to see, but this is the theory that we developed from that data, and we called this theory La Mancha Negra. And what we thought about, we got this idea from the men because they talked about this black stain that followed them throughout their whole lives. A lot of these men had, because of their social situations, because of their alcohol and drug use, they had a lot of contacts with the law enforcement. And once they had a record, as they reported, it became very hard for them to participate in or to get employment and to hold employment. So they talked about this stain following them throughout their whole lives, and the fact that it impacted them not only through substance, but also through violence. Because they didn't have any money, they had a lot more stress and they became a lot more violent. Because they didn't have any money, they turned to drugs and alcohol, which got them into trouble more deeply with law enforcement. And also because they didn't have money, they would resort to sometimes commercial sex work to help with their finances. So we saw here from these guys, and this again was just the heterosexual guys. The Hispanic MSM is in development, but this was just from the results of the focus group. So again, we had a lot of heterosexual men who were engaging in a lot of high-risk behavior. Our second study, where we looked at what factors influence substance abuse, we looked at age, years in the U.S., education, all of these things, and you can see again, I don't want to spend too much time on all this data, but the results from this study showed that we had a large sample of men in our study who were depressed. And we kind of knew this intuitively, but we saw it here. But again, these men had relatively high self-esteem. And this began, this began or allowed us to look at how self-esteem was measured among Hispanics. Was this a good variable to include? Because these men were telling us that they were very depressed, but at the same time they had very high self-esteem. So we weren't really sure at that point what contributed to that. But we also saw that a number of these guys participated in drug and alcohol use also. But predictors of substance abuse was age, of course, and also depression. And one of the things that we were really concerned about, or we were really thinking was sexual orientation a predictor? And it was not. Again, only age and depression. But acculturation was 0.06, which, like I always say, close but no cigar, or close but not only in hand grenades. But you see here that acculturation was very close, and so that again we need to look at a little bit more closely. Now we have 3 manuscripts from the Vita data that are in in the process of being written right now. We have the psychosocial and cultural correlates of depression among Hispanic men with HIV infection. We have the MSM focus groups, and we also are working up the data on comparing the heterosexual and the Hispanic MSM in terms of sexual behaviors. I also have 3 other studies that are in progress here. One is the adolescents and young adults with HIV infection that I'm finishing up data collection on this. I also have VITA-2, and that's different than the VITA-2 that we're going to be working on here at UTEP. But I also have the study that Dr. Matrani talked about that's funded by the NIH through our University of Miami Developmental Center for AIDS Research. And in this study, what I'm going to look at is I'm going to take the Hispanic cultural factors, familism, machismo, all of these factors, and I'm going to look at how they're related to sexual behaviors, substance abuse, violence, and mental health in Hispanic MSM. And I also have another study that I was working with one of our doctoral students. It's a qualitative study looking at how Hispanic MSM make decisions about sexual behaviors, and also how they do or they do not sexually negotiate in both relationships and casual sexual relationships. So where do I want to go with all of this this study? It's kind of how I feel sometimes when I'm looking at my program of research. As Dr. Matrani mentioned, I did submit an R21 to test an intervention that I've developed for English-speaking Hispanic MSM. Now, I'm focusing on English-speaking men because from my research and from previous research, we know that as men become more acculturated, they tend to pick up more risky behaviors. Not only substance abuse, but high-risk sexual behaviors. So what I'm focusing on is developing an intervention for these English-speaking Hispanic MSM that will not only decrease sexual behaviors, will also give them a perception of HIV risk, and will also encourage HIV testing. I put our publication references here. And I think I whipped through that pretty quickly, so if there's any questions, I'll be happy to answer any questions that you have. Yes, sir.
What are some of the characteristics that foreign-born men are bringing with them that's going to act as protective factors? You were saying that as they become more acculturated in the United States, they're becoming more risky.
Well, there's not a lot of research on that, at least that has to do with Hispanic MSM. There's a lot of research that looks at Hispanics in general. And Hispanics in general, if they have support, they tend to be more, not to engage in more high-risk sexual behaviors.
So those men that are foreign-born, they're actually losing the family support?
Well, that's what we kind of thought. That's what I kind of hypothesized. I kind of figured that when you emigrate, you kind of lose family support. But that may not always be the case because, as we talked about earlier, Miami is a largely a Cuban area. And there's a lot of people who emigrate who have some family here in the U.S. They may have left, some of their family behind, but they have some family here. So we're thinking that there's some of those things that, like family support, that don't promote that high risk. Now, another thing I think, too, is that in Miami, it's kind of unique because a lot of people do not speak English, and they never learn English. And so I think when you don't speak English, that limits your contact with people that do speak English that kind of engage in high-risk sex or engage in substance abuse. So kind of when you learn English, you open your opportunities to have contact with these people that are more high risk. And so I think by not acculturating and by staying more within the Hispanic community, you're less risky. Again, that needs further exploration, and there's other things that I'm sure that'll come out from that. But it's the VITA-2 study that I talked about that I'm doing in Miami. It's not only a quantitative; there's a qualitative piece too. So I'm going to ask these men, what are your protective factors? What are your risk factors? So, great question. Any other question? Yes, ma'am.
A question about alcohol use and risky sexual behavior. So you found that this is probably a moderator in mental health?
Yeah, well, in that study, we only had 100 people in that study, so we didn't want to, push it too much with so many predictors with only 100 men. But what we were thinking about there, I was thinking that alcohol use and abuse would be a direct predictor of high-risk sexual behaviors because, as we see, there's a relationship. Sometimes the more you drink, the more less, or the less inhibited you are and the more high-risk sexual behaviors that you had. And again, that needs a little further exploration because we're not really sure why alcohol was not a direct path, but that alcohol was moderated through mental health. So in that case, what's going on there? Again, I don't have the answer to that question. I mean, I can offer a few, situations that I think might be related, but I think that if the fact that it's more what's influencing these sexual behaviors of these men, it's more mental health. And alcohol use and abuse is a portion of mental health. So it's kind of all enfolded in that concept of mental health, I think. Do you have other suggestions or other thoughts on that?
In the literature, it's not, as you say, it's not established or it's not direct
Mm-hmm.
associated, but looking at this, wondering if it's because we're missing something and not looking at some aspect of alcohol use
Or also in that study, sorry to interrupt you, but also in that study, we only looked at alcohol abuse and we didn't look at other substances. So could other substances play a role in that also? I'm not sure. Again, that needs some further exploration there. Right, great question, thanks. Yes, ma'am.
First of all, I commend you for your wide comprehensive research track. My question relates to the future direction that you presented,
Mhm.
like maybe an R81, an intervention to decrease high-risk behavior.
Mhm.
Those who are over here. Have you developed your intervention?
That's a very good question. Thank you for your comments. Let's see, how do I answer that? Have I developed my intervention? Yes. I have my intervention ready to go. Again, I just need to test my intervention, excuse me. Yes, it is based on, it's based on the theory of reasoned action. Because, what you're looking at with the theory of reasoned action are intentions and also following through on those attentions and behaviors. So yes, it will be based on that. And also the intervention also will use, in conjunction with the theory of reasoned action, I also will use motivational counseling to help these men, perceive risk. We haven't ever studied or we haven't looked at with our Hispanic men in Miami, we haven't looked at if they perceive they're at risk for HIV. Okay, so we don't know that. So what I want to do is first of all start with some information, then providing them with a perception of risk, asking them, do you perceive yourself at risk? And kind of correcting that perception if the perception is wrong. For example, if someone's telling me that, oh, I'm participating in high-risk sexual behaviors, unprotected sex, I'm using substances, and I don't think I'm at risk, then we need to correct that risk through some education. And then lastly, what I would like to do with that intervention is to encourage HIV testing. Because one of my studies that I did, and I didn't present this information, there were a number of men in the study Hispanic men who had never been tested for HIV infection. Or there were a number who were tested and reported their status as don't know. For example, they said they had been tested in the last year, but their status was don't know. So either they're not reporting their status or they never went back for the results. So those are some of the things that I would like to address with the intervention. Thank you. Any other questions? Thank you all so much for your attention.